Thank you very much, Danny. And good morning again. Much of what I'm going to say is probably well known to all of you, and so we may be able to go through this presentation fairly quickly. We have several global commitments now. I think that's one thing that the TB community has been able to achieve, is that not only do we have the goals under SDG 3, which talk about the elimination of tuberculosis, malaria, HIV, AIDS, and so on, but we also have the Global End TB strategy that all the WHO member states have signed up to. And even more recently, we had the ministerial summit in Moscow in November 2017, where there were ministers from over 100 countries that came together and committed to ending the global TB epidemic. So I think that there's momentum now, there's political commitment, and this is probably the time for TB R&D researchers to really advance the field. The burden of TB is still huge and affects all countries, men, women, and children, and there has been progress, but it's been slow, not fast enough to reach the targets or make major headway in closing the gaps. Globally, TB is one of the top 10 causes of death, and with better data coming from countries with more prevalent surveys, with better modeling expertise, I think we've been able to refine the estimates for TB much better over the last few years. And childhood TB is a good example of where it was never considered to be a leading cause of death in children. But estimates from in the last few years, we've seen that the WHO global estimates for TB exceed 1 million cases in children, and a very large proportion of them seem to die even before TB is diagnosed, particularly in the under 5 age group. And therefore, TB is one of the leading causes of child mortality, particularly in developing countries. But this is a fact that's not well recognized or well appreciated by many people because it's not diagnosed and it's not there in the differential diagnosis very often. These figures from the Global TB Report of 2016 estimated 10.4 million cases, and these estimates have been creeping up over the years, again because of better data coming from countries, particularly those countries which had performed prevalence surveys and where the estimates were actually lower than what was actually found. And I'm happy that India is also well on its way to planning a TB prevalence survey, and I hope that that will be initiated within the next few months. HIV-associated TB has proportionately reduced, but still forms about 10%, but a disproportionate number of deaths occur in this group. And MDR-TB, again, has been increasing, both because of better diagnosis and detection capabilities, but also because there's probably a real increase in the prevalence of MDR-TB as drugs are getting rolled out in countries. So you can see about 500,000 MDR-TB, and if we take all forms of, if we take rifampicin-resistant TB alone, it's about 600,000 cases, and again, a very large number of deaths, a disproportionately large number of deaths in this group. Now, while TB, of course, is present in every country globally, we see that the highest incidence occurs in parts of Africa and Asia. Sub-Saharan Africa, as you can see, have the highest incidence rates of over 300 per 100,000. In some places, I think some parts of South Africa, it's even 1,000 per 100,000. And that's largely driven by the HIV epidemic. 70 to 80% of TB patients in that region are often HIV co-infected. The situation in Asia is a little different. The epidemic is not being driven by HIV, and where we see high rates, there are other risk factors like poverty, overcrowding, undernutrition, and so on that play a major role. Now, 5 countries actually contribute to 56% of cases in 2016, and that's Pakistan, China, India, Philippines, and Indonesia, all in this region. And if we add 2 more countries, Nigeria and South Africa, then these 7 countries actually account for 64% of the global cases. So we know where the problem is intense and perhaps where our action should be focused. Now you can see in this graph that the incidence rate, the case notification rates have been increasing, but we're still only diagnosing or notifying about 60% of the estimated 10.4 million cases. So the 4 million cases are often called the missing cases or the gap. And probably there's a mixed bag over there. There's, of course, cases that are being diagnosed, patients diagnosed and treated in the private sector and the informal sector who are not reported to governments. But there's also probably a lot of underdiagnosis. And as I mentioned, in childhood TB, this is particularly true, and extrapulmonary TB, there's probably a lot of underdiagnosis. So there are genuinely missed cases, but there are also cases that are not reported. Treatment success has sort of remained static, plateaued at about 83%. In fact, it's come down a little bit from the 85%. So as more and more cases are being notified, the treatment success rates are actually dropping a little bit. The global TB programs had major successes, and you can see in the last 15 years, over 56 million people have been successfully treated, and that number has been increasing with sort of constant rates of patients who die or are lost to follow-up, and treatment success rates over 80%. As far as MDR and rifampicin-resistant TB are concerned, again, 3 countries account for almost half the cases: India, China, and the Russian Federation. It is a huge public health crisis, about 500,000 new cases every year, and of them, only about a quarter are actually detected and reported. You can see that the number started on treatment is even lower, about 111,000, and globally, only about 50% of patients with MDR-TB have a successful treatment outcome, and only 3 of the 27 high MDR-TB burden countries achieved a treatment success rate of over 75%. So we have a long way to go in the management of MDR-TB, particularly in countries that have low resources. Now, if you look at 3 intersecting circles, the high TB burden countries, high MDR-TB, and high TB-HIV, then you see there are 14 countries in the middle in which these 3 epidemics actually overlap. And as I said earlier, 56% of cases are in these five countries, and India, China, and Pakistan are there in the middle intersecting circle. Now, what about India? There has been decline both in incidence and mortality. The mortality rate has certainly declined much faster, and this is a big achievement because, of course, we're talking about 1.3 billion people here. The decline in incidence has been slow, and you can see that from 2012-13 onwards, there's been an increase. The black line that's gone up there is because of the notification from the private sector that got really a big boost after 2012. So notification has been going up, but still India accounts for about a quarter of the missing cases. So about 1 million of those missing cases are in India. Again, you can see that the treatment success rates on the left, which have been fairly good, above 85% for new cases. But for MDR and XDR-TB, the treatment success is still very much below 50%. India has been increasing its national financing, and currently about less than 25% actually now. Dr. Kapade would know the most recent figures are from international donors. But of course, we have big challenges. We have geographic heterogeneity, socioeconomic determinants. In some states, the health systems are still weak, and the private sector engagement is still suboptimal. So you would have seen all the news in recent months about the high-level announcements on ending TB in India, the public-private engagement to increase notification. There's a big push now by government to improve this and to mainstream it, increasing treatment access and coverage with a multi-sectoral approach, but also for the first time, I think, a country announcing a support to TB patients in the form of a cash incentive every month for completing treatment and to help with nutrition support, I think will make a big difference. And it's more and more moving towards a patient-centered care. That's the goal of the strategic plan. At the same time, India is investing in R&D, and the idea is to try and develop better biomedical tools, which are more relevant for low middle income country context by collaboration, both national and internationally, but also with domestic investment in R&D, and also to try innovations in health systems and health delivery mechanisms. Now, I just want to mention two initiatives at the end, the Report India Consortium, and I'm happy to see many of the report collaborators here in the audience. Now, this, I think, is a really great model for international partnerships. It was a multi-organizational collaborative initiative that was initially sponsored by the US government, the NIH, and the Department of Biotechnology under the Indo-US Vaccine Action Program to address the threat of TB in India, and it's now spread to many other countries. The mission was to advance regional TB science in India, to strengthen TB research capacity and infrastructure, and to foster collaborations with US investigators and others internationally to carry out a range of basic and clinical research that could lead to advances in biomarkers, vaccines, drugs, and diagnostics. So 6 unique observational cohorts were set up, and these were conducting their own parent protocols. And then there's a common protocol that has just been implemented, where all sites would collect data and specimens according to the common protocol. 2 major cohorts, the TB disease cohort, both adults with pulmonary and extrapulmonary TB and pediatric TB, and a large cohort of TB infection, people with infection who were followed up for development of disease, and the whole thing coordinated by a leadership group led by scientists both from US and India, and these are all the partners. As you can see, there's a large central biorepository that's been developed, and a huge resource for researchers now, because this kind of biorepository is really unique, very well phenotypically characterized specimens both from TB patients, household contacts, and those with latent infection. So really that was the goal of this, to create this resource for the TB research community to investigate critical TB research questions. These were the sites. There were initially 5 sites, and then the Hinduja Hospital in Mumbai also joined in later. It's just coincidence that all the sites happen to be in the southern part of the country. I understand there's going to be an RFA coming out very soon to reopen this bid, and I hope that many more sites will be added on from other parts of the country. Just to give you a little example of the power of kind of data that can be generated when you have this type of collaborative studies and large numbers. So this shows you the prevalence of infection. Now, in the past, we've had many TB prevalence surveys done in India, infection surveys done using the skin test, of course, using PPD. And we knew that about 50% of the adult population, 50 to 60%, was tuberculin positive by the age of about 50. But this actually now gives us age-specific incidence, TB infection rates using TST, using quantiferon, and using either or both. So different combinations, as you can see in this graph. And the rates of infection among household contacts, you can see, are extremely high. And this has implications for vaccine trials. We were discussing the design of a vaccine trial that we're about to embark on with using the VPM and the MIP, Indian killed TB vaccine. And if you want to find uninfected household contacts, it's going to be very, very difficult to do that, considering that about over 70% of household contacts are infected at the time of detection of the new case. And 1 year later, when they followed up the uninfected cohort, another 15 to 20% had converted. So overall, 90% of household contacts were infected at the end of 1 year. So this is just a glimpse. There have been at least 40 publications that have come out of this collaboration and many, many conference presentations. So it's really already having returns, I think, much more than what was considered. And as I mentioned earlier, there are now multiple international consortia. And I think we must acknowledge the role that Peter Kim from the NIAID played really in conceptualizing this whole thing. So we can see now China, Philippines, Indonesia, South Africa, and Brazil all have their own cohorts. So again, this is going to be a wonderful resource for researchers, but also setting the stage for trials like vaccine trials, because the baseline data have already been conducted in these populations. And finally, the India TB Research Consortium that we set up in 2016 at the ICMR was formed to address gaps. And as I said, the Indian government has invested over $25 million now over the next 2 years just on this consortium. It brings together ICMR, DBT, the Department of Science and Technology, and multiple other partners within India, including many of the funders. It's focused on translational research, so we really want to move tools quickly out into patient use. It's not focused on basic research. For example, we've conducted a 100-site study of TrueNat, that's a new molecular diagnostic developed by an Indian company. There are at least 4 clinical trials now in the pipeline for both drug-sensitive and drug-resistant TB, and a large vaccine trial among 20,000 household contacts, testing 2 different vaccine candidates, the MIP and the VPM, and I think you'll be hearing more about this in subsequent sessions. We're hoping now that this would expand into a BRICS R&D network or international R&D networks, and that other countries, middle-income countries like India, will also start investing much more in TB research. I thank you very much. I thank Christian Lienhardt for assistance with some of these slides, and many other collaborators and partners from around the world who have contributed. Thank you very much.